Patients here.
Oh boy, got some blood going.
Yeah, there's blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in emergency
in your left hand.
For 45 minutes of CPR. We can stop CPR with 600, 600, 600.
Imagine, for a second, a heart the size of a strawberry. It's beating 150 times a minute. It's essentially sprinting a marathon, but the baby is lying completely still in a plastic warmer.
Yeah, and then you introduce a structural flaw. The
Yep.
plumbing is just, it's wired wrong.
Exactly. The pipes are crossed, or maybe a wall is missing, or a valve is basically welded shut.
It's a mechanical nightmare, and for the parents, it is, it's absolutely terrifying.
Right. And now, put yourself in the shoes of the nurse standing at that bedside. You have to infuse a medication into that tiny system.
Yeah.
If you get the math wrong, or if you push it too fast, or miss a subtle cue on the monitor,
You could stop that heart.
or stop that baby from breathing.
That is the reality of the pediatric cardiac ICU. It's high stakes, high stress, and incredibly precise. The margin for error is, well, it's effectively zero.
Which is exactly why we're doing this deep dive. We aren't just reading drug labels today. We've taken this massive stack of textbooks, clinical guidelines, and drug monographs resources that would honestly take weeks to digest. And we're filtering them. We're looking for the Pareto principle.
The 80-20 rule.
Exactly. We want the 20% of the pharmacological knowledge that is going to drive 80% of your clinical decisions and, answer 80% of those really difficult board exam questions.
So if you're prepping for the NCLEX, or if you're just trying to survive your first shift with a blue baby, this is what you need.
This is your roadmap. And we should be really clear about the scope here. We're going to touch on defects, tetralogy of Fallet, transposition of the great arteries, but only as context. We aren't teaching pathophysiology today.
No, we're teaching the chemical tools you use to manage it, to fix it.
We have 4 main stops on this roadmap. First, we've got ductal dynamics. These are the drugs that manipulate the fetal bypass.
The on-off switch.
Then the failure fixers, how we manage volume and squeeze. After that, rhythm and flow, controlling the speed and the thickness of the blood.
And finally, the acquired trio, the diseases kids can catch that actually attack the heart.
It's a heavy list, but we are going to break it down so it sticks. So let's just get right into it. Section 1, ductal dynamics. This is the battle between open and closed.
Right, and looking at the literature, everything here, it just revolves around one single structure, the ductus arteriosus.
Okay, so set the scene for us. Biologically, what are we actually looking at?
You have to remember that a fetus doesn't use its lungs.
Yeah.
In the womb, the lungs are fluid-filled and they're under high pressure. They are, for all intents and purposes, closed for business.
But the heart is still pumping.
The heart is still pumping blood. So nature created this incredible bypass road, a physical vessel called the ductus arteriosus, and it connects the pulmonary artery directly to the aorta.
So blood leaves the right side of the heart, it heads toward the lungs, hits a road closed sign, and just takes the ductus off-ramp straight to the body.
Precisely. It skips the lungs entirely because the placenta is doing all the breathing for the baby.
Okay, so what happens at birth?
Well, normally, when a baby is born and takes that first breath, 2 things happen. The lungs expand, which drops the pressure, and the oxygen levels in the blood just shoot up. That surge of oxygen triggers a chemical reaction that clamps that vessel shut.
That's just gone.
Usually within a few days, it's totally closed. It becomes a ligament. It's not a factor anymore.
But here's the crux of the problem for congenital heart defects. In some of these babies, that closure is catastrophic.
Great. If you have a defect like pulmonary atresia, where the normal road to the lungs is completely blocked, or maybe hypoplastic left heart syndrome, where the road to the body is blocked, that ductus is the only thing keeping the baby alive.
It's the only bridge.
It is the only bridge allowing blood to get where it needs to go. If nature takes its course and closes that duct, the baby dies. It's that simple.
So we need a chemical doorstop. We need something to physically jam that pathway open until the surgeons can get in there and operate.
And that brings us to drug number 1, alprostadil.
Also known as prostaglandin E1 or PGE1.
Yeah. If you work in an ICU or a CVICU, This is arguably the single most critical drug in your crash cart. It is a lifesaver.
Let's start with the basics. Drug description. I'm looking at the monograph here, and it just says it's a potent, smooth muscle relaxant.
And that's the key phrase. The ductus is a muscular vessel. Alprostadil tells that muscle to relax. Just chill out.
Yeah.
By relaxing, it prevents it from constricting.
It maintains ductal patency.
That's the term you'll hear in report. We're running prostin to maintain patency.
Okay, so let's dig into the mechanism of action. It's relaxing the smooth muscle. How?
It binds to prostaglandin receptors on the muscle cells of the ductus. This activates a cascade inside the cell that basically prevents calcium from entering. Without that influx of calcium, the muscle just can't contract. It's forced to stay dilated.
So practically speaking, if I'm in report and I hear the phrase ductal-dependent lesion, my brain should immediately jump to alprostadil.
Instantly. It's a direct one-to-one link. If the baby's life depends on the ductus being open, this is the drug they will be on.
Let's talk about specific defects. The outline links this to transposition of the great arteries, or TGA.
Right. In TGA, the plumbing is completely swapped. The blue blood from the body goes to the right heart and back to the body. The red blood from the lungs goes to the left heart and back to the lungs.
They never mix.
They never mix. It's two separate circles. That baby will die from hypoxia within minutes unless you have somewhere for the blood to mix. The open ductus allows that. It lets some of that red oxygenated blood cross over into the aorta and get to the body.
So it's a bridge. What about something like tricuspid atresia or pulmonary atresia?
In those cases, the valve leading to the lungs is either missing or sealed shut. No blood can get from the right side of the heart to the lungs the normal way. The ductus is the only source of pulmonary blood flow.
So blood goes from the aorta backward through the ductus and into the pulmonary artery.
Exactly. It's a reverse flow, but it's the only way to get blood oxygenated.
Okay. And on the other side of things, hypoplastic left heart syndrome, HLHS.
In HLHS, the entire left side of the heart is underdeveloped. It can't pump blood to the body. So again, the ductus is the only source of systemic blood flow. The right ventricle pumps blood to the pulmonary artery, and then it crosses the ductus to get to the aorta and feed the body.
So in all these cases, if that duct closes, it's game over.
Game over.
Now, when we start this infusion, what are we actually watching for? How do we know it's working? This is the core need-to-know stuff.
The therapeutic effect depends entirely on the defect. It's all about what you're trying to achieve.
So if the baby is blue cyanotic because blood can't get to the lungs, like in pulmonary atresia.
You watch the O2 sats,
Yeah.
you start the drug, and you should see the baby literally turn pink in front of your eyes.
Yeah.
The saturations climb from, say, the 50s or 60s up into the 80s.
And if it's an obstructive lesion, like a severe coarctation of the aorta where the aorta is pinched?
Then you're watching for perfusion. Before the drug, the baby might have cold legs, pale skin, and you can't feel the femoral pulses. The blood pressure in the legs will be way lower than the arms.
Right.
You start the alprostadil, the duct opens, and it provides blood flow to the body after the pinch point. Suddenly, you can feel pulses again. The lactate levels, which were high from poor perfusion, start to drop. The baby looks, for lack of a better word, alive again.
That sounds like a miracle drug, but looking at the side effect profile here, this is rough. There is a boxed warning that seems to be a favorite for exam writers.
Apnea.
It stops them from breathing.
It's a very, very real risk. Alprostadil has a central effect on the respiratory drive in the brainstem. The data says about 10 to 12% of neonates will have an apneic spell.
1 in 10.
Yeah, and it usually happens quickly, typically within the first hour of starting the infusion.
This feels like a massive trap for a new nurse. I can see the exam question now. You start alprostadil on a newborn with TGA. 15 minutes later, the baby stops breathing. What is your priority action?
And the distractors will be things like stop the infusion or administer epinephrine or call the provider. All sound plausible.
But you do not stop the infusion.
Never. That's the trap. If you stop the infusion, the duct closes and the underlying heart defect kills the baby. Apnea is a known, expected side effect, not an allergy.
So you treat the side effect.
You treat the side effect, you get your bag valve mask, you support their breathing, and you call for help to get them intubated. You ventilate them. But you keep that prostaglandin running at all costs.
So the number one nursing implication, the absolute safety priority, is never start this drug without an airway cart at the bedside.
Correct. Intubation equipment, suction, a ventilator immediately available. In fact, if we're transporting a baby on alprostadil, say, in a helicopter or ambulance, we almost always intubate them electively beforehand.
Proactively.
Exactly. You do not want to be trying to intubate a tiny, unstable neonate in the back of a moving ambulance because the drug kicked in and they stopped breathing. It's all about anticipation.
That makes perfect sense. I also see fever and flushing listed here as a common side effect. Is that an infection risk?
Usually not. It's a systemic vasodilator. It opens blood vessels everywhere, not just the ductus. So the baby turns red, gets hot to the touch. It can look really alarming like a sepsis flare, but it's usually just the drug working.
So you treat the temperature, maybe unswaddle them, but you don't panic and start a sepsis workup immediately.
You don't panic. You also need to watch for cardiovascular collapse, so hypotension and bradycardia, if the baby is particularly sensitive or if the drug is pushed too fast. But apnea is the big one, the one you have to be ready for.
What about administration? Can I run this through a peripheral IV in the hand?
You can, but it's risky. It's tough on the veins and you can lose access. Ideally, you want a secure central line or a UAC and umbilical artery catheter. And here is a rigid rule. This is continuous infusion only.
Meaning no interruptions.
0 interruptions. You never flush the line, you never bolus it, and you absolutely never let the bag run dry.
Because the half-life is incredibly short.
Seconds to minutes. If that pump beeps infusion complete, and you ignore it for 5 minutes while you go get another bag, the duct can start to spasm shut. Wow. And once it clamps down, it is very, very hard to pry it open again. The standard of care is to have the next bag mixed and ready, and you run 2 pumps to switch it over so there's literally 0 interruption in the flow.
That's a huge nursing responsibility.
It is. It's a life-sustaining infusion.
Okay, any nice-to-know facts about alprostadil before we move on?
Well, the name itself comes from its discovery in seminal fluid from the prostate gland. It's also used for erectile dysfunction in adults in products like Caverject or Muse. Same molecule, totally different application.
Fascinating.
And one other thing for kids who are on it long-term, like for weeks while awaiting transplant, it can cause something called cortical proliferation, which is a weird thickening of the long bones. It's reversible, but something to know.
Okay, so alprostadil jams the door open. But let's flip the script. Sometimes we have the opposite problem. The heart is structurally normal, but the baby is premature and the ductus won't close.
Right. This is the classic Patent Ductus Arteriosus, or PDA. In a preemie, the lungs are incredibly fragile. If that duct stays open, high-pressure blood from the aorta floods into the low-pressure pulmonary artery.
It's called pulmonary overcirculation.
Exactly. The lungs get wet, heavy, boggy, the baby needs more ventilator support, and the heart eventually fails trying to pump against all that extra flow.
So we need to do the opposite of alprostadil. We need to close it. Enter drug number 2, indomethacin.
Indomethacin, an NSAI. It's in the same family as ibuprofen or Motrin.
But we aren't giving it for a headache or a fever.
No, we are using its primary mechanism of action as our therapeutic effect. Indomethacin is an inhibitor of cyclooxygenase enzymes, KOX1 and KOX2.
And QS enzymes are the factories that build prostaglandins.
I see you're making the connection.
Yes. Alprostadil is a prostaglandin. It keeps the duct open. Indomethacin stops the body from making prostaglandins in the first place.
Exactly. You fire the construction crew, no COX enzymes, no prostaglandins. And since the ductus needs a constant supply of prostaglandins to stay open, without them, it loses its signal and it constricts.
It's a chemical clamp. It sounds brilliant, but looking at the safety data, indomethacin feels like a dirty drug. It hits a lot of different systems.
It does. It's not a precision weapon. It's more like a shotgun.
Yeah.
And the 2 battlegrounds you have to watch very, very closely are the kidneys and the gut.
Why the kidneys? What's the link?
Because prostaglandins play a huge role in maintaining blood flow to the kidneys, especially in a fragile, stressed newborn. They keep the renal arteries dilated. When you give indomethacin and wipe out the prostaglandins to close the heart duct,
You inadvertently clamp down on the renal arteries, too.
you do. You can cause a significant reduction in renal blood flow, leading to an acute kidney injury.
So what's the nursing implication? What do I monitor?
Urine output. Meticulously. You're calculating it every hour. If the urine output drops, if you see oliguria, or if the baby becomes anuric with no urine at all, you have to hold the drug. You also monitor the serum creatinine. If it's elevated, that's a red flag.
So the exam question might describe a preemie with a PDA scheduled for indomethacin, but their creatinine is high and their UOP is low.
And the answer is, hold the drug and notify the provider.
Yeah.
You cannot sacrifice the kidneys just to close the duct. You might have to go to surgical ligation instead.
Okay, that's the kidneys. Now the gut.
Same mechanism. Reduced blood flow, this time to the intestines. In a premature baby, this is the absolute nightmare scenario. NEC, necrotizing enterocolitis.
Where the bowel tissue literally dies.
It dies because it isn't getting enough blood. Bacteria invade the bowel wall and the gut can perforate, spilling stool into the abdomen. It's a surgical emergency with a high mortality rate.
So as a nurse, what am I looking for?
A distended, firm, shiny belly. Bloody stools, you might need to do a guaiac test on the stool. Vomiting, especially green, bilious vomit. Any of those signs are a hard stop.
So the big contraindications are active bleeding, like an intraventricular hemorrhage, existing kidney problems, or any signs of NEC.
Correct. You have to assess for those things before every single dose.
What about the therapeutic effect? How do you know it worked?
You listen to the heart. A PDA has a very characteristic machinery-like murmur. After a course of indomethacin, that murmur should be gone. You'll also see the baby's respiratory status improve. They'll need less ventilator support because their lungs aren't flooded anymore.
Is there anything in the nice to know category for indomethacin?
Yeah, another 5E NSAI called ibuprofen lysine is sometimes used as an alternative. Some studies suggest it might have slightly fewer renal side effects, but indomethacin is still the classic prototype you'll see on exams.
And it can mask a fever, right? Since it's an anti-inflammatory.
It can. So you can't rely on temperature as your only sign of infection in a baby getting this drug. You have to look at the whole clinical picture.
Okay, so ductal dynamics in a nutshell. Alprostadil opens the door but might stop the breathing. Indomethacin slams the door but might starve the kidneys and gut.
That's the 80-20 right there. Understand that prostaglandin switch, and you understand both drugs.
Perfect. Let's move to section 2, the failure fixers. We've managed the plumbing, the ductus, but now we have to deal with the pump itself. A lot of these kids, whether they have a hole in the heart like a large VSD or an AV canal defect, they have a heart that is just boggy, it's volume overloaded.
They're in heart failure.
Yeah.
And it looks just like adult heart failure, but in a tiny body. You see periorbital edema, puffy eyes, tachypnea, so rapid breathing, and a classic sign in babies is sweating while feeding.
Diaphoresis with feeding.
That's the term. It's like they're running a marathon just to drink a bottle. It's a huge red flag.
Right.
And they fail to thrive because all their calories are being burned just to breathe and pump. The heart is just drowning in fluid.
So our first job is to unload the wagon. And that brings us to drug number 3, the gold standard for this, furosemide.
Lasix, the absolute workhorse of pediatric cardiology.
The class is a loop diuretic. Let's break down the mechanism of action in simple terms. How does it actually get fluid out of the body?
It works in a specific part of the kidney called the ascending loop of Henle. In that spot, it blocks a transporter protein that's responsible for reabsorbing sodium, chloride, and potassium back into the blood.
And water follows salt.
Water always follows salt. If the kidney can't reabsorb the salt stays in the urine, the water stays with it, and the baby just pees out a huge volume of fluid.
Simple enough. You give the drug, the diaper gets heavy, the lungs get clearer, the breathing gets easier. That's the therapeutic effect we want.
Right. Decreased edema, clear lung sounds on auscultation, and an improved work of breathing.
But diuretics, especially loop diuretics, are famous for messing with electrolytes. What is the specific imbalance we are terrified of with Lasix?
Potassium. Lasix is a potent potassium-wasting diuretic. It kicks potassium out right along with the water. You are at a very high risk for hypokalemia, low potassium.
And why does low potassium matter so much for these cardiac kids?
2 big reasons. First, low potassium makes the heart muscle irritable. It can cause arrhythmias, PVCs, even more dangerous rhythms. But the second reason is a classic drug interaction that is pure exam gold.
Digoxin.
Digoxin. Many of these heart failure kids are also on digoxin to help the heart squeeze more effectively.
And I remember this from nursing school. Potassium and digoxin compete.
They compete for the same binding sites on the heart muscle. Think of it like a game of musical chairs. If potassium levels are normal, there's healthy competition. But if potassium is low, there are all these empty chairs, and digoxin can just bind everywhere way too aggressively.
And you get digoxin toxicity.
You get dig toxicity. And the earliest signs in an infant are often GI-related. Vomiting is number 1. Not just spitting up, but real vomiting.
So the nursing algorithm, the exam question is, a child on Lasix and digoxin starts vomiting. Your first action is?
Check a potassium level immediately. Do not just assume it's the flu or reflux. Vomiting is often the first and only sign of dig toxicity in an infant.
So as the nurse, you're monitoring serum potassium levels like a hawk, and you're probably administering potassium supplements like K-Dur or IV potassium chloride.
Constantly. It's a daily battle to keep their potassium in the normal range.
There's another major safety warning here for Lasix that I think a lot of people miss. The monograph highlights ototoxicity.
Yes. Hearing loss. This is almost always associated with IV administration, and specifically with pushing it too fast.
How does that happen?
If you slam IV Lasix, it rapidly alters the electrolyte balance in the fluid of the inner ear, the endolymph. That sudden shift can damage the delicate hair cells that are responsible for hearing.
And is that damage permanent?
It can be. Often it's transient, but do you really want to be the nurse who made a child deaf because you didn't want to stand at the bedside for 2 extra minutes?
Absolutely not. So what is the speed limit?
The rule of thumb for pediatrics is you do not exceed 0.5 milligrams per kilogram per minute. For a bigger kid with a high dose, you are not slamming it in like a saline flush. You are pushing it slowly, over several minutes.
Or putting it on a pump.
If the dose is large enough, we often just put it on a syringe pump to run over 10 or 15 minutes, just to be absolutely safe. Slow and steady saves the hearing.
Okay, we've diuresed them. We've lowered the preload, the amount of volume filling the heart. Now we need to help that tired heart push blood out. We need to lower the resistance it's pushing against.
We need to reduce the afterload.
Which brings us to drug number 4, lisinopril.
An AC inhibitor. That stands for angiotensin-converting enzyme inhibitor.
Right, so this drug's mechanism is blocking the conversion of angiotensin I to angiotensin II.
And angiotensin II is one of the most potent vasoconstrictors the body makes. It clamps vessels down tight, which jacks up the blood pressure. By blocking its production, lisinopril lets the arteries and veins relax and dilate.
So it lowers the blood pressure.
It lowers the blood pressure, which makes it much easier for a weak, failing heart to empty its chamber. It's like trying to push open a heavy, spring-loaded door versus a door that's already wide open. It reduces the heart's workload.
Now, let's contrast this with Lasix. We just said Lasix dumps potassium. What does lisinopril do to potassium?
It does the exact opposite. ACE inhibitors are potassium-sparing. By blocking part of the hormonal cascade, they decrease aldosterone levels, and aldosterone is what tells the kidneys to excrete potassium. So they make the kidneys hold on to potassium.
So we have a perfect balancing act. The Lasix is pushing potassium out, the lisinopril is holding it in.
In an ideal world, they cancel each other out beautifully. But you have to monitor the lapse. You can't just blindly give potassium supplements if, say, the Lasix is held for a day, but the lisinopril is still given. You could easily swing them into hyperkalemia.
And high potassium is just as dangerous as low potassium.
It can cause fatal arrhythmias. It stops the heart.
Okay, there are 2 other classic exam favorite side effects for ACE inhibitors. One involves the face.
Angioedema.
And the other involves teenagers.
Let's do the face first. Angioedema is a rare but life-threatening allergic reaction where the lips, tongue, and airway can swell up. It can happen after the very first dose or after years of being on the drug.
So if a parent calls and says his lips look weird and puffy after his new heart medicine,
that is a 911 call. That is a medical emergency. They need to go to the ER immediately.
And the teenagers.
Teratogenicity. It's a huge one. ACE inhibitors are a boxed warning for fetal toxicity. They are absolutely contraindicated in pregnancy.
They cause fetal renal failure and death.
Yes. So we're in pediatrics, and we often forget to think about this. But if you have a 16-year-old girl with cardiomyopathy who is on lisinopril,
you have to have the awkward conversation.
You have to. She cannot get pregnant while on this drug. It is category X.
Yeah.
If she's sexually active, she needs reliable contraception. It is a mandatory part of your nursing education and documentation for all adolescent females of childbearing potential.
It's a huge liability point. Okay, Lasix and lisinopril are sort of the daily maintenance crew, but sometimes, especially post-op, you need a heavy hitter to control acute hypertension. That's drug number 5, hydralazine.
Hydralazine is a direct-acting vasodilator. It doesn't mess around with the whole RAAS system like ACE inhibitors do. It goes straight to the smooth muscle in the arteries and tells it to relax.
And its effect is pretty rapid.
Very rapid, especially the IV form. It decreases systemic resistance and lowers blood pressure fast. We use it a lot for post-op cardiac kids who come back from the OR with hypertension.
But the body has a compensatory mechanism, right? You drop the pressure suddenly and the body panics.
It does. It's called reflex tachycardia. The body's baroreceptors sense the sudden drop in pressure and they send an uh-oh signal to the brain. The brain then tells the heart to beat faster to try and bring the pressure back up.
So you give IV hydralazine, the blood pressure beautifully drops from 110 down to 90.
But the heart rate spikes from 120 to 150.
Is that considered a failure of the drug?
No, it's an expected physiological response. We anticipate it.
Yeah.
But you need to monitor for it, and often these patients are also on a beta blocker, which helps to blunt that tachycardic spike.
I found a weird nursing tip in the notes for hydralazine regarding its interaction with metal.
Yes, this is an old school but vital piece of information. Hydralazine can undergo a chemical change. It degrades and changes color if it sits in contact with metal for too long, like in a stainless steel medicine cup, or if drawn up with a metal needle and left to sit.
So the rule is you don't pre-draw this medication and leave it on the counter for an hour.
Never. You draw it up and you give it immediately. If you notice it's changed color, you have to toss it. It's a sign of chemical degradation and loss of potency.
All right, that covers our failure fixers. Let's shift gears to section 3, scenario specifics. We are moving away from general heart failure and looking at specific, terrifying events that happen with certain defects. Let's talk about the TET spell.
The hypercyanotic spell. This is the hallmark of tetralogy of Fallot, or TOF.
Okay, quickly, what is the core problem in TOF?
You have 4 defects, but the one that matters for spells is a narrowing of the pathway to the lungs. Pulmonary stenosis, combined with a big hole between the ventricles, a VSD.
So describe the physiology of a spell. What is actually happening?
So that pathway to the lungs is already narrow. But sometimes, usually during an event that increases oxygen demand like crying, feeding, or having a bowel movement, the muscle right below that narrow valve, it's called the infundibulum, goes into a sudden severe spasm.
It's like a fist closing around the hose to the lungs.
That is a perfect analogy. It clamps shut. Now, deoxygenated blood coming into the right ventricle has nowhere to go. It can't get to the lungs, so it takes the path of least resistance, which is across the VSD, into the left ventricle and out to the body.
But this is blue, unoxygenated blood.
Exactly. So the baby turns a deep, profound blue or purple almost instantly. Their oxygen saturation plummets into the 30s or 40s. It is terrifying to watch.
We need a drug to break that spasm. Enter drug number 6, propranolol.
Propranolol is a non-selective beta blocker. It blocks the effects of adrenaline and the sympathetic nervous system on beta-1 receptors in the heart and beta-2 receptors elsewhere.
How does that help break the spell?
But blocking the beta-1 receptors, it slows the heart rate and, crucially, it reduces the force of contraction. It relaxes that spasming infundibular muscle. It loosens the fist.
The pathway to the lungs opens back up.
It opens back up, blood can flow to the lungs again, and the baby turns pink.
So propranolol is usually given as a daily maintenance drug to prevent these spells from happening in the first place.
Correct. But let's simulate the emergency. You're the nurse. A baby having a TET spell is in front of you. Do you run for the propranolol first? No, absolutely not. The very first thing you do is change the physics of the situation. You put the baby in the knees to chest position. You take the baby's knees and you push them up firmly against their chest.
Why does that work?
It kinks the femoral arteries in the legs. This dramatically increases the systemic vascular resistance, or SVR. By making it harder for blood to flow down to the legs, you increase the pressure on the left side of the heart. This encourages the blood in the right ventricle to choose the now easier path to the lungs instead of shunting across the VSD.
So it's a mechanical fix.
It's mechanical fix. So
Yeah.
it's knees to chest, try to calm the infant, apply oxygen, and then you might give IV morphine, which also helps relax the spasm. Propranolol would be more of a second-line IV intervention in the acute spell, but its primary role is prevention.
You mentioned propranolol is non-selective. That means it hits beta-1 and beta-2 receptors.
Which is a major problem if your cardiac kid also has a history of asthma.
Why?
Because the beta-2 receptors are what keep the airways, the bronchioles, open. If you block them with propranolol, you can trigger a severe bronchospasm, a massive asthma attack.
So an absolute key nursing consideration is to check the patient's respiratory history. Cardiac kid plus asthma, propranolol is probably not the right choice.
You'd want to use a cardioselective beta blocker instead, like metoprolol or atenolol, which primarily hits beta-1.
There's one more tricky interaction with propranolol that is a favorite for exams: diabetes.
Yes. Beta blockers mask the signs of hypoglycemia. Normally, when your blood sugar drops, your sympathetic nervous system kicks in. You get jittery, sweaty, and your heart races. That's your body's alarm bell telling you to eat.
But beta blockers stop the jitters and the tachycardia.
They block that whole response.
Yes.
So a diabetic child on propranolol could have their blood sugar drop to a dangerously low level without anyone noticing until they become lethargic or even have a seizure.
So you have to be hypervigilant with blood sugar monitoring in that specific population.
You absolutely do.
Okay, let's talk about the other big scenario: clots. Kids with complex heart defects are full of plastic tubes, artificial shunts, patches, and areas of sluggish blood flow. All of this is a recipe for thrombosis.
Which brings us to heparin, drug number 7.
Heparin is an anticoagulant. Its mechanism is that it potentiates the body's own natural anti-clotting factor, antithrombin III.
Right. It basically supercharges antithrombin III, making it hundreds of times more effective at inactivating thrombin and other clotting factors. It doesn't break down existing clots, but it stops them from getting bigger and prevents new ones from forming.
We use this a lot after surgeries, especially with palliative shunts like the BT shunt.
A Blalock-Taussig shunt is a tiny Gore-Tex tube, maybe 3 or 4 millimeters wide, that connects an artery from the aorta to the pulmonary artery. It's a lifeline for babies who need more pulmonary blood flow. If that tiny tube clots off, the baby dies. Heparin is critical to keep it patent.
The primary risk, obviously, is bleeding. But I want to focus on the fatal error warning mentioned in the sources. This is something that has tragically killed patients.
The concentration error. This is one of the most feared medication errors in all of nursing. Heparin comes in vials that can look frighteningly similar but have vastly different strengths.
You have the flesh concentration.
Which is very dilute, maybe 10 units per ml or 100 units per ml. It's used just to keep IV and central lines from clogging up between uses.
And then you have the systemic or therapeutic vial,
which can be 1,000 units per ml,
Yeah.
5,000 or even 10,000 units per ml. That is a potential 1,000-fold difference in concentration.
And if you grab the 10,000 unit vial thinking it's the 10 unit flush.
You give a massive overdose. You effectively exsanguinate the patient internally.
Yeah.
Their blood becomes unable to clot at all. In a tiny neonate, this is almost always fatal. It's caused well-publicized deaths.
This is why heparin is a mandatory 2-nurse check in almost every hospital in the country.
It has to be. You have to physically get a second licensed person, show them the vial, read the concentration out loud, and show them your calculation. I have heparin, 10,000 units per ml. The order is for 100 units. I have drawn up 0.01 mLs. They have to verify every step.
And you can't rely on the color of the cap.
Absolutely not. Manufacturers change cap colors all the time. You have to read the words on the label.
If you do make a mistake, or if the patient just starts hemorrhaging for other reasons while on heparin, is there an undo button?
There is. It's protamine sulfate. That is the specific antidote for heparin. It binds directly to the heparin molecule and neutralizes it. You need to know where that is kept on your unit, because when you need it now.
And what are you monitoring for a patient on a continuous heparin infusion?
The APTT, or activated partial thromboplastin time. That lab value tells you how long it takes the blood to clot, and you adjust the heparin drip rate up or down to keep the APTT within a specific therapeutic range.
Okay, we are in the home stretch. Section 4, the acquired heart disease meds. These are kids born with structurally normal hearts who get sick. We have a trio here: Kawasaki disease, rheumatic fever, and infective endocarditis.
Right. These are inflammatory or infectious processes that attack the heart.
Let's start with Kawasaki disease. This is the vasculitis known for the high fever, the rash, the strawberry tongue.
The real danger with Kawasaki is not the rash or the fever. It's that the immune system launches a massive inflammatory attack on the blood vessels, and it has a scary affinity for the coronary arteries.
The arteries that feed the heart muscle itself.
Yes. It can cause coronary artery aneurysms, weak, ballooning spots in the vessels. These can lead to blood clots, heart attacks, and sudden death, even years later.
And the treatment regimen for Kawasaki involves 2 key things, one of which is a drug we are rigorously taught never to give to children.
Aspirin.
Right. Every nursing student learns that giving aspirin to a child with a viral illness can cause Reye syndrome, a devastating condition that causes liver failure and brain swelling.
And that is absolutely true. But Kawasaki is the one major exception to that rule. The risk of a permanent coronary artery aneurysm is so high, and the anti-inflammatory and antiplatelet effects of aspirin are so beneficial that we accept the small risk of Reye's.
So we give very high doses of aspirin initially to cool down the inflammation, and then a low dose for a long time to prevent clots.
Exactly. And the second part of the treatment is a massive dose of IVIG intravenous immunoglobulin.
What's the thinking there?
IVIG is a product made from the pooled antibodies of thousands of blood donors. Giving a huge dose of it seems to reset or modulate the patient's own haywire immune system, stopping it from attacking the blood vessels. It dramatically reduces the incidence of coronary aneurysms.
But there's a logistical catch with IVIG that's a big deal for pediatric nurses. It messes with vaccines.
It does. Because IVIG is just a soup of antibodies, if you give a child a live vaccine, like the MMR for measles, mumps, rubella, or the varicella vaccine for chickenpox, right after they've received IVIG.
The antibodies in the IVIG will just attack and kill the weakened vaccine virus.
And the child's body never gets a chance to build its own immunity. The vaccine just won't take.
So what's the rule?
The rule is you must delay all live virus vaccines for 11 months after the IVIG infusion. This is a huge teaching point for parents at discharge. You have to make sure they understand why their child's vaccine schedule is being altered.
Okay, finally, let's touch on rheumatic fever and infective endocarditis. These are both bacterial in origin.
Correct. Rheumatic fever is a post-infectious complication of untreated Group A strep throat. Endocarditis is a direct bacterial infection of the heart lining or valves.
The 80-20 here seems to be about the duration of antibiotic therapy. These are not your typical 5-day courses of amoxicillin.
Not even close. For infective endocarditis, you have these clumps of bacteria called vegetations growing on a heart valve. It's incredibly difficult for antibiotics to penetrate that biofilm. These kids need 4 to 8 weeks of high-dose IV antibiotics, usually something strong like penicillin G or vancomycin.
So they are going home with a PICC line and home health nursing.
It's a huge commitment for the family. And for rheumatic fever, the issue is preventing recurrence. If you've had it once, your heart valves can be damaged, and you're very susceptible to getting it again with another strep infection.
So these patients need long-term prophylaxis.
Yes, they might be on monthly injections of long-acting penicillin until they are 21 years old, or sometimes even for life, to protect their heart valves from further damage.
It's a huge burden. Okay, so looking back at this entire roadmap, we've covered a lot of ground. We have the ductal duo.
Alprostadil and indomethacin. The opener and the closer.
Watch the breathing for the opener, watch the kidneys for the closer.
Exactly.
Then we have the failure fixers, Lasix, and lisinopril.
Watch the potassium. It's a seesaw. Lasix wastes it, lisinopril saves it, and always check a potassium level if a baby on digoxin starts vomiting.
We have the scenario managers, propranolol for TET spells, heparin for clots.
Knees to chest first for the spell,
Mm-hmm.
and read the vial out loud for the heparin twice.
And finally, the acquired trio, where we break the aspirin rule for Kawasaki and give IV antibiotics for weeks on end. What is the big so what here? Why does this specific level of detail actually matter at the bedside?
Because the margin for error in a 3-kilogram baby is non-existent. A misplaced decimal point in a dose calculation isn't just a paperwork problem, it's a stroke. It's renal failure, it's a dead baby.
It's about anticipation.
That's the word. If you know alprostadil causes apnea, you aren't staring at the monitor in shock when the alarm goes off. You are already standing there with the bag valve mask in your hand. You move from being reactive to being proactive. That is what saves lives.
And before we wrap up, I want to leave you with one final thought that really struck me while researching alprostadil. We treat these drugs like these very sterile industrial chemicals, but nature is incredibly efficient. Do you know where prostaglandins were first discovered?
In seminal fluid.
Hence the name, prostaglandin. It was first isolated from the prostate gland. The exact same molecule that biology uses for reproduction is the molecule we use to keep a blue baby alive until surgery.
And it's the same molecule used in drugs like Caverchect for adult erectile dysfunction. It's just a tool.
It's just keys and locks.
Oh.
The body reuses the same key for different doors. It just makes you wonder, what other off-label miracles are sitting in our pharmacy right now just waiting for someone to figure out that a key for one condition fits a completely different lock somewhere else?
It's a fascinating field. Biology is always smarter than we are. We're just trying to catch up to its designs.
Keep your drips timed, check your math twice, and trust your gut. We'll see you in the next deep dive.